Under the current guidelines in 2007, there are no specific pregnancy-related recommendations for hepatitis A post-exposure prophylaxis. The work group discussed a number of issues relating to hepatitis A and pregnancy. First, a study by Merle et al. In 2014 on hepatitis A vaccine safety during pregnancy found no pattern of adverse events in pregnant women or their infants following vaccination during pregnancy. Second, the work group discussed a review published in November 2015 that found that generally, infants born to mothers with hepatitis A infection are healthy, with rare exceptions. However, the review also found that while hepatitis A infection during pregnancy is generally not associated with serious outcomes, there is some association between infection and preterm labor, placental abruption, and premature rupture of membranes. There does not appear to be an increased risk of mortality for either the mother or baby associated with hepatitis A infection during pregnancy. And third, of note, the vaccination of pregnant women who have a specific risk or who lack a risk but want protection is included in the CDC adult immunization schedule under medical and other indications. The work group perspective included that administration of Hep A vaccine during pregnancy is safe. Risk of gestational complications exist if a pregnant woman is infected with hepatitis A virus. Vaccine provides long-term protection. IG administration in addition to vaccine can be considered based on infection risk. A summary of proposed recommendations for hepatitis A post-exposure and international travel are shown here. The changes just discussed are outlined in red.
Okay, do we have questions for Dr. Nelson? Dr. Belongia.
This doesn't directly relate to the vote, but I'm curious, you outlined some of the challenges of IG. Is there any better technology on the horizon? Are people looking at monoclonal antibodies in the future? Are we likely to have some better options than IG? Or are we stuck with IG for the long term?
Not that I'm aware of.
Dr. Lee.
So 2 questions. One for the 6 to 11-month-old age group. Are you recommending revaccination after they return once they age into the appropriate category?
Yes. So they would still receive the 2 doses of vaccine after 12 months of age. They would not be able to receive that first dose until at least 6 months after.
And then the second is related to the pregnancy question.
Mm-hmm.
And I wonder if you have any estimates of the number needed to vaccinate to prevent an adverse outcome of pregnancy due to hepatitis A infection.
I do not have that number. No. Sorry.
Do you have an estimate of the number of women who might be prophylaxed? Do we have a guesstimate?
Dr. Newsel.
Kathy Newsel, IDSA. I have some concern, and it may be confusion, but I'm worried if I have the confusion, others might have it, with the caveat for the measles issue. You know, I travel and work all over the world. We know that measles occurs in low resource and high resource places. We know it's highly transmissible. And outbreaks have occurred, you know, because of transit through airports and in at Disney World, for example, or Disneyland. So again, I just want to be sure that we want to have that exception, and I think it will be very difficult to interpret from the practical standpoint.
The work group has discussed that, and certainly something to consider if that exception is needed.
Dr. Kimberlin? Dr. Brady?
Yeah, so kind of related to that, I'm just wondering if the contraindication of giving the measles, mumps, rubella vaccine and the hepatitis A vaccine is based on data suggesting either increase in adverse events or an impact on immunogenicity, or is that just because there's no data that they can be given simultaneously?
So I think that there's some confusion about the measles language, because I think sometimes what you had up on the slide didn't exactly coalesce with what you were saying. So can you just re-summarize what cannot be given together and what can be, please?
I'll just verbally say it. So immune globulin, so hepatitis A immune globulin cannot be given concurrently with MMR vaccine.
But the hepatitis A vaccine and the MMR can be given together?
The vaccines can be, yes.
Okay, so that makes it a lot easier. Okay, thank you.
Everybody get that? Because it was pretty confusing as we were going through it. It took me a little bit to, but everybody's clear. So it's this question of being able to give the hepatitis A vaccine with MMR. Yes.
Can you just restate the current recommendation?
Sure. The current recommendation is that hepatitis A vaccine can be given to infants greater than equal to 12 months of age. Okay.
So this is the 6-month to 12-month period that we're talking about. Go ahead, Dr. Walder.
Yeah, I tend to agree with Kathy. I think for practical purposes, for that 6 to 12-month age range, for the practitioner who has both of these vaccines in their office to try and figure out where a measles endemic area is and where there's an outbreak, it's really going to be difficult. So, why are we making that distinction?
No, we can certainly consider, the vote without that distinction.
Dr. Romero, do you want to clarify that?
No, I mean, I was about to say we can certainly move that off, but the group considered it to be something to discuss for the ACIP. I mean, I think if it is causing a lot of confusion, and it did, I mean, the language did, I have to admit, we did discuss it, and afterwards it seemed prudent to leave it in, but if it is causing a lot of confusion, then we can remove that and still leave it as using vaccine.
Dr. Atmore?
I want to come back to the post-exposure recommendation for the 40 to 50-year age group. So it appeared to me from the data that were presented that the immunogenicity in the 40 to 50-year age group is inferior to that of younger age groups and not as inferior as over 50. But with an incubation period of 2 to 6 weeks for hepatitis A, having more than 20% of people in that age group, 40 to 50, not have quote-unquote protective level of antibody, I guess is a little bit concerning to me. And I wonder whether or not the work group considered just removing the preferential recommendation for IG in that age group and making either, I mean, currently vaccine is really has a secondary role, but either being possibilities if the implementation is considered to be such a problem. I guess we don't really have data to say whether it's going to be equally efficacious, and we're not likely to get any, and so I just am a little bothered by the inferior immunogenicity in that age group. I mean, that was listed as a consideration for over 50, and I think it's still a consideration for the 40 to 50 based on the data presented.
Thank you. Dr. Moore.
Thank you. I think the intent of the work group in leaving in the comments about IG for that 6 to 11 month group was, and I certainly think it would be much simpler to say vaccine, just give both vaccines routinely, but in some cases it's still acceptable to give IG if the clinician and the family prefer to administer IG, but only in situations where they're going to places where measles has been eliminated. So I think it was meant to not say that a medically appropriate product that can protect against hepatitis A should no longer be used under any circumstances. We didn't want to go that far. But I certainly think it could be more simply stated that both vaccines should be used for MMR and hepatitis A in that age group. If there is a clinical decision about IG, it will protect against hepatitis A in that age group, but there are stronger considerations around measles protection that should be borne in mind.
Dr. Massonier.
Yeah, thank you. I have a question about the 6 to 12-month-old or 6 to 11-month-old age group. Do you know how many infants there are in this category that we're wondering about that would, be in the category of needing vaccination? And also, where are they getting seen? Because I think this clinical decision-making looks different if it's a average pediatrician who's trying to interpret this versus, for example, somebody whose specialty is travel medicine, who is probably much more aware of what we mean when we say measles endemic countries.
I'm not aware of the number of infants that this affects, but my understanding is that the majority of these infants at that age range would be seen at the general pediatrician.
Ms. Pellegrini.
I'd like to know if the work group talked at all about the nature of exposure for persons over 40 and stratifying based on that. It sounds, if I'm understanding right, like the IG is providing short-term protection for a few months, and that would perhaps be most appropriate for, say, a foodborne exposure, which is going to be, hopefully, a one-time episode. However, if you're homeless or an IV drug user, that's probably going to be a long-term ongoing exposure where the vaccine might be more appropriate. Did the work group consider breaking things down that way?
So the guidance that would be accompanying this discusses the risk. So if the person is of a high, falls into one of the hepatitis A vaccine risk groups, such as MSM or IV drug use, they would get vaccine, and then there could be the addition of immune globulin, particularly if they're immunocompromised or have chronic liver disease. The 90-day, 30 days after vaccination is about 90% or more seroprotection. So the concern is really in that 15-day window while that immune response is increasing.
Dr. Moore.
In response to this, from a programmatic standpoint, I think one of the major considerations around IG is that most health departments don't have it readily available, most clinicians don't, and time is of the essence in these situations. When we find people who have been exposed, it's often right at the end of that 14-day window when we actually track them down. And the intent here is to ensure that the clinician gives what is readily available immediately, which is the vaccine. And then if they need to scramble to get that IG because they need to provide more assurance, they can do that, but they haven't wasted time saying, well, come back when I get the IG. Let's get that vaccine in them today and then figure out what we need to do. And that's something that I think will help us programmatically provide more efficient protection to more people who need post-exposure prophylaxis who otherwise might miss the window of opportunity for protection at all.
Dr. Zahn?
Yeah, and as part of the work group, I think another one of the considerations when you're describing the nature of the exposure, the one biggest issue local public health runs into is an awful lot of these exposure events are foodborne exposure situations. And so in that scenario, we very often at the beginning, you don't know how many exposures you have, and you may have people who are in the hundreds or even in the thousands. And in general terms, the risk of that sort of exposure is a lot lower than someone who is a household contact of someone. And so, I'll admit in terms of the driver of these age groups, to me, local public health driver is You know, if you have 1,000 people who've been exposed and several hundred of them are in an older age group, you're just not going to be able to get a hold of immune globulin very often. And so, you know, having vaccine at least as the option really is, you know, something that's a lot more practical and deserves consideration. So that's at least one of the thoughts here.
Thank you. Dr. Kimberlin.
David Kimberlin, AAP Red Book. Seeking clarification, the middle row that says healthy persons greater than 50 years of age, the data on one of your earlier slides on seroconversion at 15 days was 50 through 59 years and a second row of greater than or equal to 60 years. Should that be greater than or equal to 50 years of age, or do you literally mean a 51-year-old and older?
So currently, the recommendation is for including age 40. So it would be 41 to 50, and then 51, 59.
So 41 through 50, and then 51 and up, even though the earlier slide was showing 50 through 59-year-olds. It's the dash that's the issue.
Yeah. So I guess it would depend on what makes most sense in terms of understanding. I think since right now the recommendation is up through age 40, and then the next increment would be 41 through 50, and then the next increment after that would be 51 through 60, so greater than 50 years.
Dr. Messonnier.
I was going to ask Dr. Ward maybe to make a comment about the intent of these recommendations.
Yeah, what we're trying, I think, as some of the comments already reflect, where these changes reflect that vaccine does afford protection at any age for a sizable proportion of the population, but that in some situations for the older group that's at the highest risk for severe hepatitis A, immunoglobulin is appropriate, but it sort of depends on the situation, and that's where the provider guidance comes into play to help providers understand when IG is really the most indicated versus some of these other exposures where vaccine is more practical.
Thank you. Dr. Romero?
So given the confusion and the suggestions that were made, it may be more appropriate to take this back to the work group, smith the words together and make the recommendations a little clearer for everybody, and bring it back in June. That's what I would propose.
Is there any objection to that from the committee?
Okay, we'll do so.
Any further comments for the work group to take back?
I do just want to make the comment that we have 2 individuals signed up for public comment prior to this vote, but since we're not taking a vote on this issue, I would like to put those 2 public comments to the end of the day with the rest of the general public comments.
Dr. Stevens?
I just for information for the working group, I would second Dr. Admar's concern about the reduced immunogenicity in the 40 to 50 age group as a guideline.
And that will be one of the things we look at again.
Okay, thank you very much. This has been a great discussion, and I think that, you know, there's no great urgency about taking this vote today, so I think Dr. Romero's request is well taken. I think we will go ahead and take a break. We're actually 15 minutes early, so could I ask that people be back at 10:15 from the break so that we can then start the influenza session? Thank you.